Maddie Sterling is an assistant professor in the Division of General Internal Medicine. And she has a career development award in which she's looking at issues related to home health care workers. And she's going to be talking to us today about the experiences of home health care workers in New York in the context of the COVID-19 epidemic. And to those who are not aware, she published a paper on this topic this week in the journal JAMA Internal Medicine. And I suspect that paper is at least somewhat related to the obviously very interesting and important presentation that we're about to hear.
Great. Thank you, Dr. Shapiro, for that introduction. Can everyone hear me? I'm going to just look in the chat box. If hopefully one person will say they can.
Yes.
Okay, great. Today I'll be presenting It's Not Just a Job Where You Can Work From Home, Experiences of Home Healthcare Workers in New York City during the coronavirus disease 2019 pandemic. This project is obviously a collaboration that takes a village, especially during a pandemic. So I want to just acknowledge the groups at the top. So researchers from Cornell Tech, Cornell University, ILR School, and my community partner, the 1199 SCIEU, which I'll talk about briefly in a few slides. I don't have any disclosures, and funding for this project was from the Robert Wood Johnson Foundation, as well as the NHLBI. So let's talk a little bit about home healthcare workers, and I want to talk about them in the context before COVID, because much of my work will talk about what happened to this workforce during COVID. So home healthcare workers are one of the fastest growing sectors of the healthcare industry and US economy. The picture on the right is from the front cover of the New York Times back in 2017, highlighting a home health aide. And there are nearly 2.3 million currently, but the demand for them is increasing. And this is in part because of our rapidly aging population that wishes to remain at home. And so by 2026, estimates suggest that about 4.2 million home care workers will be needed to fit the needs of community dwelling adults. When we say home healthcare workers, this is really an umbrella term, but mostly they are trained and certified health professionals who provide what I like to call daily or near daily, so a few times a week or every day, personal, emotional, and medically oriented care to adults in the home. And what does that mean? Well, for those of you like me who are in medicine, or for those of you who had a parent who needed a home health aide or a grandparent, you know, this is really sort of helping with activities of daily living, showering, bathing, instrumental activities of daily living, as we call them. So grocery shopping, meal preparation, and then also, like this picture shows, helping, reminding adults to take their medications, helping them get to and from doctor appointments, helping with wound care, taking vital signs like blood pressure. So it really runs the gamut, their responsibilities. I will note that there are different types of home health care workers, and these are home health aides, and then attendants and personal care aides. That is a talk for another day to talk about the nuances of each of these specific roles. But I want to just say that collectively, this group really provides what I like to think of as the eyes and ears in the home. So spending a lot of time in the home with patients, often way more than some of us medical professionals get to. I'd also like to show that sort of despite this high involvement in the everyday lives of adults, they tend to be, this workforce is vulnerable. They tend to be women, majority of women do this job, racial and ethnic minorities, foreign born, especially here in New York City. But you know, well-educated, many actually use this job as a home healthcare worker as sort of an entree into other health-related professions, so working also to get their degrees in other sort of health-related fields, but really, you know, working at a local minimum wage. So here in New York City, that might be $15, but around the country, that might be $11 an hour. And I want to just show that this vulnerability has been showcased a bit in the lay press and the news. And here are some clippings over the years from the New York Times, where you can see that, that people have pointed out this vulnerability. So this is sort of the workforce pre-COVID and the issues that they face. And I like to call this sort of overlooked and undervalued, meaning sort of always present with patients, but really not valued or seen by the medical system or society at large oftentimes. So let's switch into coronavirus, which I know there are folks on the line from our 3 campuses, and so some of you may be more involved in the medical aspects of the COVID-19 pandemic than others. So I just want to broadly remind everyone that, although I don't think anyone needs reminding, you know, over the last several months, unfortunately, we faced a very severe pandemic. COVID-19 is caused by the severe acute respiratory syndrome, coronavirus 2 or SARS-CoV-2. It's spread by droplets and airborne transmission, although on surfaces as well. And really what we've seen is that the clinical presentation, often, you know, shortness of breath, cough, fever, you name it, it can run the gamut from a mild sort of flu-like illness all the way to a severe illness that requires, you know, ICU level care and intubation. As many of you have been reading about, or those of you in the medical field know, the treatment thus far has been primarily supportive, meaning oxygen, antipyretics. But obviously, as we've learned more about the disease, we've learned more about what treatments are more efficacious than others. And obviously, there are many clinical trials going on, as well as vaccine trials. Again, because now we're in August, but I just want to take a step back because the work I'll be presenting actually occurred in March and April, the study. So I want to just show you where we were and where we've been. This is the coronavirus in the United States. This was data taken from the New York Times on July 31st, so on Friday. At that point, we had 4.5 million cases, over 150,000 deaths in the United States. You can see that in New York City, this is our map. We were the epicenter originally. We experienced a very large, as many of you know, peak back in March and April, and things have since calmed down. I don't want to say we're anywhere near back to where we were. I'd say we're in a new normal. And the study that my team and I did occurred in March and April, which I'll get to in a few slides. Before going into my work on home healthcare workers, I want to just show you kind of the New York City and our healthcare system. And these are some articles, you know, for those of us who are in the thick of it, I don't think we need to see these, but for some of us, I think it's nice just to take a step back and see where we were. You know, captions like "It feels like a war zone," "Doctors and nurses plead for masks on social media," an article written by one of our own hospitalists in the New Yorker, "Adrenaline, duty, and fear inside the New York hospital taking on the coronavirus." And then below, sort of this, what happens if there aren't enough of us healthcare workers, meaning doctors and nurses, to fight the virus. So these were back in March, some of the articles about us and our healthcare system and our workforce. And after the attention on doctors and nurses, there was then also in the lay press and, you know, a swing towards, well, there's all these other support workers in the hospital that keep our hospital going and all these ICUs going. And this article even shouted out physician assistants, pharmacists, and respiratory therapists. So there was then this attention that, hey, it's not just the docs and nurses, there's a whole support crew of healthcare workers in the hospital that are keeping patients alive. And these are some covers from Time magazine over time. On the left, you'll see a paramedic being highlighted from New Jersey. On the right, all the way on the right, you can see someone in the lab equipment doing microbiology samples. And in the middle, actually, food care, so cafeteria workers in Dallas were being highlighted. So, you know, in the lay press, a lot of these health professionals, not just doctors and nurses, over time were being showcased, and rightly so, as heroes during the crisis. I also want to give a shout out, and as many of you know, I'm a health services researcher, but you know, to the incredible scientific response that was going on during the clinical response. So as you can see here, this was a search I did on PubMed on Friday. There's 36,000 articles on COVID since this started. Thanks to the new PubMed features, it provides a nice timeline of these. And the majority are cohort studies, so characterizing who is hospitalized, what predicts mortality, what predicts survival. I know folks in our research group have been really dedicated to that. Clinical trials that have come out regarding new medications, review papers looking, across the world, how do cases present elsewhere, and then of course perspective pieces. But this all sort of hit me at the time, and even now, to think, well, what about home care? We know that only the most severe cases were coming to the hospital, and that begged the question for me, especially as a primary care doctor, what about all the people that are coping with coronavirus at home and the folks that are helping them? And has there been any work to detail what's been happening and what are the struggles there? And there started to be some lay press on this. This was an article from April, home healthcare workers in the US at the tipping point amid coronavirus outbreak. Here was a feature by the New York Times. They look after our most vulnerable. They make around $16,200 a year. Are we okay with that? And then the Brookings Institute put this out again back in May. Essential but undervalued, millions of healthcare workers aren't getting the pay or respect they deserve in COVID. And so the lay press started to pick this notion up about what's happening in the home. But as you can see, the time on those picking that up was really towards the latter end, after a lot of other types of healthcare professionals were the focus initially. As a researcher, I wanted to know, well, has anyone studied how workers are coping, what's been going on? And I found that there were really just a few sort of local and national needs assessments, mostly about personal protective equipment. There were a few perspective pieces. A couple of us in this group have, in the Center for Health Equity, wrote one. Recently, there have been many fabulous studies, very rigorous, on nursing homes and sort of the epidemic in that part of long-term care. But really, there were no formal studies on home health care and the workers. And so that left me and my team, my co-PI, Dr. Nikki Dell at Cornell Tech. The two of us have a grant together from Robert Wood Johnson, which looks at equity among this workforce. And we sort of put our heads together in mid-March and said, late March, and said, what can we do about it? Because there seems to be a lack of data. And this is what we did. So just to set the stage, I'm trying to sort of do that in terms of the need, but sort of the scientific rationale for this work is that, home healthcare workers play an important role in supporting patients in the home, including those with suspected or confirmed COVID. As many of you know, early on in the pandemic, we could not test everyone, so we don't actually have a sense of how many people had it back then. But these workers are also quite vulnerable, as I've tried to show you, before COVID. And so it's likely, we hypothesized, that they might face even greater challenges during COVID. And so our objectives were twofold. One, we wanted to understand the experiences of home healthcare workers caring for patients during the COVID pandemic, and to do that here in New York City at the height of things. And then understand specifically the challenges they were facing. This is a workforce who faces challenges every day at baseline. So what were the challenges in COVID, which we hoped once we figured those out, that could then inform future interventions or policy solutions which might mitigate them. And so as several of you, I know there's social scientists on the call, when there's really an area that's been understudied and you want to understand sort of the lived experiences, often a qualitative study is a really good way to start. So we embarked on a qualitative study from March 26th to April 30th. We included English-speaking home healthcare workers who were currently employed by a licensed or certified home care agency in New York City. And to do this research, it really had to be community partnered. And we relied on our community partner, the 1199 SIEU, Home Care Industry Education Fund, which has been, I've been working with them collaboratively for the last 4 years on a number of studies with home healthcare workers. Just a little bit about this because I think it's a really important piece of the research, and I know in our Center for Health Equity, community engaged research is vital. So the Home Care Industry Education Fund is actually a benefit fund within the largest healthcare worker union in the United States. Fortunately for us, they happen to be located in Times Square. So the headquarters are nearby, and during the year when we're not on a travel ban with social distancing, I typically meet once a month with the community partners. This is an education fund, so it's a benefit fund that serves 75,000 home healthcare workers from 55 agencies across New York City. And what does that mean? Well, they provide quality training and education to home care workers. So once you're a home care worker, it's not just that's it, you have to do annual training and service hours, and so they provide that. They also help them sort of meet the changing and emerging needs of the industry. So whenever there's any sort of upgrade or standards, they have to provide training around that. They also provide benefits, English language classes, career advancement opportunities, and promote growth and empowerment in the workplace. And so with our community partner, they approached us, actually, the backstory is they approached us on this, that they felt, we approached them and then they said, you know what, we could really, someone needs to tell the story of what's happening with our workers. And so we said, okay, we can do a study if we can get it together and do it virtually. And so that's what we did with the help of research assistants or member relations staff at the Benefit Fund. We used a pre-written script to recruit workers for the study. And we used what's called purposeful sampling, whereby we selected workers from a broad array of agencies and boroughs. So you could imagine that if I were to go and study home care workers from one agency, although those findings might be interesting, it's hard to understand if they would apply to a variety of agencies across the city. And so by using purposeful sampling, we're basically able to capture a wide variety of agencies. And then because COVID affected different boroughs, I felt it was important that we sample from every borough of New York to make sure that we also had the most diverse perspectives possible. We conducted one-on-one interviews through Zoom. So for those of you looking to do studies remotely during the pandemic, feel free to reach out to me at the end. This was a new skill for all of us. We used verbal consent to do these. We provided gift cards digitally to participants, and we got this study IRB approved rather quickly, actually. So what did we ask participants? Well, we focused broadly on 3 main things. What did you know about COVID? How did COVID affect your work? And what are some challenges you experienced as a worker during COVID? So really kept it simple. Obviously, each of these questions, along with like all qualitative research, had a full set of probes. And so please reach out to me. I'm happy to send you the full topic guide. It's also available online at JAMA Internal Medicine. We wanted to make that fully accessible should anyone want to repeat our study in the future. And then like qualitative studies, we recorded these interviews on Zoom. They were then professionally transcribed. We had a 5-person coding team, several PhD students, fantastic from Cornell Tech, research assistant from Weill Cornell, myself and Dr. Dell. And then we analyzed the data using grounded theory, which is an inductive coding approach. We did this because there wasn't really a conceptual model for how these workers respond in a pandemic. And so we really wanted to understand the data from the bottom up without overlaying a theory to it. In total, we had 91 unique codes. And again, I'm happy to share that codebook is also available online. These grouped into 17 sub-themes, and ultimately we ended up with 5 themes for this analysis. So I'm going to go through the results, which include the participant characteristics, the themes, sub-themes, and then also some quotations, because I think it's important that the voices of the workers come through more than hearing my voice. So overall, we recruited 33 home care workers who were employed by 24 unique home care agencies across the 5 boroughs of New York. Their mean age was about 47 years. 97% were women. The majority were Black and Latino. You can see that education-wise, this was similar to our prior studies, relatively educated with some college or colleges more in a majority of folks. And you can see that this group had actually a lot of experience as a home healthcare worker with an average of 10 years on the job prior to this study. Of the 33 participants, 4 of them said during the interviews that they suspected or had confirmed COVID. This is a map that our team created, which just showed the locations of the home care agencies where the participants were employed. And we don't need to count up the stars, but each star represents a headquarters of an agency. So for example, you could be worker A in the Bronx, and you could have a job in the Bronx and then another client who's in Queens, but for the sake of this study, your agency was located in the Bronx. So what were the 5 major themes of this analysis? The first was that home healthcare workers were on the front lines of COVID-19 medical management, but felt invisible. The second was that there was heightened risk for COVID-19 transmission to both patients and themselves. Third was that we found that there were really varying levels of support from home care agencies, and this included information about COVID, but also personal protective equipment, or what we call PPE. Due to this varying level of support, we found that workers relied on alternative sources of support, so sort of outside of their agencies. And finally, as a function of all of this, we found that workers were forced to make tough trade-offs between their own health and finances. I'm going to go through each themes and then the sub-themes within them so you get a better sense of what these mean. So on the front lines of COVID medical management, but invisible. So we found that workers during COVID were providing day-to-day care for patients with chronic conditions. So everything that I showed you on almost slide 2, all of that personal and medical care. But in addition to that, they also now had to, on top of it, monitor patients for COVID and also take a lot of COVID precautions in the home. Here's an example of this. One participant said, I will ask them how long they've had the cough. I know even with the cough, you can't go to the ER, so I'll call the doctor who will give us information. Then I'll try that. So this was early on in the pandemic when not everyone was able to there wasn't capacity in the hospital. So you see the worker is managing kind of both regular symptoms plus COVID. And then also taking a lot of precautions in the home to prevent COVID. So we found that workers were cleaning constantly, changing their uniforms, washing down things. And here's a quote from a worker who talks about the environment in the home itself. So it's become a very stressful environment. She watches the news constantly. As soon as I set foot in the door, did you see this? Did you see that about coronavirus? So kind of being around it all day in the home. Unlike sort of in the medical field, this is a really one-on-one job in the community. And yet, despite sort of all of these activities that they were engaging in, the majority of workers we spoke to actually reported feeling invisible. One said, we're definitely a forgotten field. You hear people clapping, thanking doctors and nurses, even the hospital cleaning staff. I'm not doing this because I want praise. I love what I do, but it would be nice for people to show us gratitude. A second worker says, it makes me very upset and just angry because people don't acknowledge healthcare workers. And I think at the end of the day, we are just as reliable, and I think we are just as important as nurses and doctors. We deal with these clients on a regular basis. I think we know more about these clients than doctors and nurses do. And then after they get discharged from the hospital, it's us who has to take care of them. So this general feeling of invisibility we found was heightened during COVID, invisibility that they felt even pre-COVID. Let's talk about risk for COVID transmission. And this happened in a couple of ways. On one hand, A lot of workers talked about sort of, they were worried about transmitting it to patients. Many of them, because their role was to protect patients, which tended to be frail older adults or those with disabilities and chronic conditions, a lot of these patients were kept socially distant and isolated. But as a result, the workers felt like, they could give it to them. So I feel guilty because since they're not going outside, I know if they catch it, it's because of me. And that's my fear going to work. So we found that this weighed on them. We also found that it weighed on them, sort of this idea that they could also contract COVID. So he needs to stay inside the house. So he tells me, I need you to go there and go here. I really don't want to, but I can't say no. I'm the aide. I'm supposed to do this. So we found that aides were often the ones going to grocery stores, going to pharmacies. They were essential workers trying to protect their patients. Sometimes they volunteered. And in this case, sometimes, the patient asked them. But in either way, they felt like this increased their risk of getting the disease. I think in New York City, we found, alarmingly, that workers were talked about sort of public transportation as an issue. I take 3 buses to get to work, the number 9, the 19, and the 5. That's a lot of traveling and being around different people. So, this was a job where you had to get to the job, and to do that required often for these low-wage frontline workers relying on public transportation. Unlike our hospital where there were shuttles and such, it's not like agencies were able to sort of provide transportation to workers to protect them in getting to their job. And then there's the concept of that in home care, there's often shifts. And so there were often numerous workers per patient. And this, of course, could theoretically increase the risk of spread. One worker said, there are 5 of us that work with her. What happens if we all get sick? Let's talk about varying levels of support from agencies. So we found, as you might imagine, by including workers from 24 agencies, we found that there were differing amounts of information on COVID being communicated to various workers. So on one hand, you have a worker who says, nobody ever told us you got to take precautions and blah, blah, blah. Nobody tells us anything. And on the other end of the spectrum, you hear, to see their concern and the agency reaching out each and every one of us and letting us know that they care, it just really touched my heart. So we saw this wide variation in agency support. Personal protective equipment and it being limited in the home care sector was a big issue. And one worker said, I'm worried about getting infected because I don't have the right equipment. The agency has not really been providing it for their workers at all. So this is an instance where a worker felt like they were just not getting gloves, masks, all the things they would need. Another instance is if workers were getting it, they didn't know how long it would last for. So I'm wearing a mask 24/7, but I don't know how long that's going to last. There's a limited amount you can get from your job. I'll also say that we heard that many workers had to actually physically go to their agency to pick up the equipment. It was only later in the pandemic that agencies were able to mail it out, if you will. And so you could imagine that even the trip to the agency, which might mean for some workers several boroughs away, also created some anxiety and risk for transmission. We found that COVID-specific training was lacking. So this means sort of providing education around the disease and precautions in general. Some agencies were better than others. We found that workers said, some agencies were being asked to screen themselves every day. They text a 4-question screener every day. They want to know if something changes in your body. Do you have a fever? Do you have a cough? So this is an instance where they were sort of being trained and then being asked to screen. Although on the other side, a worker says the agency hasn't really been able to provide us with any training. This came so fast, meaning, COVID came on from really quickly. And so they felt like they weren't just getting the training when they needed it. And what we found is that actually due to sort of this variable support, they tended to rely either on themselves or others. So information was one big source of need for workers. And so we found that they were kind of getting it from everywhere if it wasn't coming from their agency. I watch the television, the news, I listen, I read on my phone, like on Facebook. I try and read about it everywhere. Obviously, you can imagine that some of these sources are more credible than others. And then some workers who felt like they weren't getting enough equipment or they didn't have what they need were actually buying it out of their own pocket, which you could imagine was terribly financially draining. I spent $20 to get a box of masks. I walk all over to buy a small can of Lysol for $7. And then peer support, so talking to each other. We talk to each other. We need to protect ourselves for the clients if you want to keep working. And actually, I'll say this was a change from before. Home care is a job that sort of one worker goes into a home, does that job in relative isolation, goes home to their own family. In the case of COVID, we found that more often workers were sort of increasing their network and contacting each other for moral and sort of emotional support during all this and for information. I think taken together, we found that there were a lot of trade-offs being made by workers. One was sort of weighing the risk of exposure versus working. So I'm living with my daughter and she has young children. If I get infected, I could infect my daughter's family. So in this case, a worker is grappling with, well, do I keep working because it will affect people in my own household if I were to get sick? In other instances, people were weighing financial implications of working versus not. So although, one person says, you have to continue certain hours to get benefits, as much as I would like to stay home and stay safe, I have to go out there because I have bills to pay. So, although we'd like to, a lot of us, in academia have the privilege and ability to work from home, this is really, one worker says, is just not a job where you can work from home. And of course, the financial ramifications of turning down cases are really astounding for this workforce. And finally, we saw this trade-off between, and I think a lot of us in medicine felt this way too, sort of this risk of getting it versus this duty or calling to provide care. And we found that that was very similar in home care. So one worker said, I see a fire. Am I going to walk right into that fire? Well, if I have the backup, the proper gear, yes, I'm going to be there on the front lines to help that person. So these were the 5 themes. Hopefully you have a better sense of them now. And so what did we conclude from this study? We found that sort of 4 main things. Despite providing essential care, home healthcare workers generally felt invisible during this. There were PPE shortages and heavy reliance on public transportation. This, coupled with them sort of as a vulnerable population taking care of another vulnerable population, increased their risk of transmitting and contracting COVID. There were also sort of physical and mental implications for this, so a lot of anxiety among workers about sort of this risk of transmission. But we found that despite these risks, many just could not afford not to work, and others also worked just out of a sense of duty. Overall, caring for patients during COVID, it really exacerbated this workforce's existing vulnerabilities and professional challenges. As with any study, there are of course limitations. So the first is that we really can't generalize our findings to non-English speakers. Although most of the studies that my team and I do are in English and in Spanish, just given the rapid pace of doing this study, we focused on English speakers for this one. We're now trying to replicate in Spanish. Obviously, the pool of workers we studied were unionized and worked for licensed agencies. As some of you may know, there are home care workers who are paid by family members off the books or work in what we call the gray market or in non-licensed agencies. And obviously these findings don't apply to them or can't be generalized to them. And then finally, this was a study in New York City. And so it's hard to say whether it would generalize beyond our region. I also want to just highlight that our study does not include the perspectives of other key stakeholders. And so we did this study early on in the pandemic, and just like in healthcare, guidelines were rapidly changing, and We don't include in this study the perspectives of home care agencies themselves, who were likely also in a very challenging position during COVID. And so just be aware of that, that while we have one set of perspectives, we also, we can't sort of propose that we know the side of the agency in all this. We have a few hopes for this work. One is that it raises awareness of this workforce's contributions during COVID and the continued challenges they face. And the second is that the work can help to advocate for policy change, which may better support the workforce. So by generating the data, can we put that in the hands of policymakers? Some of the key issues right now are that, essential worker designation around the country, PPE, so having adequate and enough PPE and having it paid for, sick pay, and training. Those are sort of the four big policy issues that are plaguing this workforce right now. And we hope that this work can kind of stimulate conversations around those issues. Our research team, in terms of next steps, is now working on a large-scale survey, basically taking these qualitative findings and adapting them into a quantitative survey to test these in a larger scale. We're also interviewing agency leaders because, as I said before, I think their perspectives are absolutely critical to understanding how COVID affected home healthcare landscape in general. And then finally, looking at some policy changes and how that affects the landscape. So, for example, we've had a lot of swing towards technology and video visits in the primary care world. And so there have been changes with telemedicine to home care as one example. Other changes, there have been sort of relaxed guidelines as to training or online training. And so understanding kind of what all this means for the workforce and then for patient care in the future is going to be really important. This study took a village. I'd like to first acknowledge the participants who gave, time when they didn't have time to share with us their stories. Our study team, which included Emily Tseng, Anthony Poon, Jacqueline Cho, Lisa Kern, Ariel Avgar, Claire Nkuda, and Nicola Dell. None of this work could be done without all of them. Of course, our community partner, and particularly two staff members, our community partner who worked tirelessly to help us recruit workers. Our funders, and of course the Center for Health Equity, to which we've been collaborating across our 3 campuses now for a couple of years, and I think the center has really fostered that culture, at least for our group and for many others. I'm going to stop here. We have about 15 minutes left, and I'll take some questions. I'll also point you to the article that's now online, and JAMA also did a podcast with us, so you can hear a live interview, and there's some commentary from home care experts and the editors at the journal about the article. And I think they make some really excellent points about this workforce that luckily, I didn't have to make. They made the case about sort of the inequities and where this work could stimulate action. So I encourage you to take a listen on your, on not your commute, but on maybe if you have some spare time. Thanks so much.
We're certainly open for questions. Maybe I'll begin with one. It's a very powerful presentation and very chilling, really, that these people are being subjected to the worst of the lack of social distancing. And can't help but think about the concept of ancillary healthcare workers. The term ancillary actually comes from the Latin, which means maid, servant, or slave. And that seems to be a fair description of the situation that many of these people are in. I was wondering, Maddie, if you've had any opportunity to explore how home care is operationalized and practiced in other countries, that the ones maybe with more rational or reasonable healthcare systems. Do these workers have more rights, more?
Yeah, that's a great question, Martin. It's interesting. I think in Canada, which I know is your home country, I think that they are doing a bit better in terms of having more designation and awareness of their status. I don't know the data on wages there, so I can't speak to that. I do know that I currently collaborate with caregiver researchers in Italy, and we have a couple of studies underway there. And I know that in Europe, some European countries like Italy, there aren't really union or agency status. So a lot of workers are hired privately by families, which of course is something that occurs here in New York, obviously in the United States. And so the problem, there's pros and cons of that, just like we see here, in that if you have a worker hired privately, if the family treats you quite well and pays you well, then that is fine. But unfortunately, sometimes this doesn't happen, and there aren't the same training standards or certainly healthcare benefits that, let's say, by being employed by an agency that's part of a union could afford. So I think, to answer your question, I haven't done as much international work as on this topic as I'd like to, but I think from the countries that I am aware of, there's a variable experience, and it really depends on how the system is set up with payment incentive and also who's doing the hiring and employment.
Well, certainly as you're building your repertoire of studies and bibliography in this area, I think might be useful to do more international studies. Presumably one of the reasons why you're interested in this area is you see this as a group of people who have not been well treated in our society and would like to figure out what are the policy levers for improving it. Of course, more knowledge in this era doesn't always lead to rational decision making, but it can't hurt.
Sure. I'll also point out that in the United States and elsewhere, there's a lot of enthusiasm around community health workers. And a question I frequently get asked when I give talks is, well, are these the same as community health workers? And I hope I've shown you that actually this workforce is its own designated set of healthcare providers with training and certification. And I think one thing that my hope is for this research is to elevate kind of, oftentimes these workers are kind of there in plain sight almost. I think, I got inspired to do this work as a primary care doctor when, I had several patients who said, Dr. Sterling, why are you asking me? My aide Marie is in the waiting room. Do you want to bring her in and have her join us? And so I think what's interesting is that these workers are, as I said, are the eyes and ears and observing, and yet to date really have not been given that status, I think, that they deserve and incorporated into the healthcare system.
Well, and as you're implying from this study, and certainly evident in previous studies that you did, not even being able to be told by the agency what the condition is that they're expected to help the individual with, in this case, is outright dangerous. It's kind of a physical assault upon them, but it's certainly making them a HIPAA inclusive part of the healthcare system would be a step in that direction.
Yes, absolutely.
Maddie, thank you again for a terrific talk and incredibly important work bringing this information to light. I had two questions. One, you mentioned that you're reaching out to the agencies to find out sort of what their experience was during the same time period. Are you looking to see how much information they gave to patients, what their version of, yes, we gave them all the information we had, it was difficult because it was changing times, we didn't have PPE to give them, sort of hearing their side as well?
Yeah, hi, Dr. Pausman. Do you want me to answer that one first?
Yeah, and the second part of that, not the second question, but is also the union's version of this and how they're representing their workers. And then I'll ask the second question after you finish that one.
Absolutely. And I actually have a few slides on kind of what has been the response so far. But I would say, and I'll preface this by saying that because we are in a Center for Health Equity talk, and I think this is so important, we actually held a town hall on Tuesday when the study came out, where we presented the findings to workers, agencies, union members. So there were 96 people who attended. And in the last couple of weeks, we've been interviewing agency leaders and union workers. Agencies we're finding, and this is all preliminary, I haven't analyzed it formally, but agencies were really stuck, between a rock and a hard place. Unlike the healthcare system, their margins are incredibly, even our margins, as we know in primary care, are tough. Home care is even tougher, and so the guidelines were rapidly changing. The guidelines for home care were even lower on the totem pole than they were to get, for some of us. And so not only were they constantly, we found so far, feeling like they were behind the 8 ball, but then they had to adapt. So if the DOH said, okay, today workers are considered essential, now they all need masks and goggles. Well, agencies did not have the bargaining power to go and obtain those. And so what we found is that it was almost like through private donations, and some agencies with more recognition than others had the equipment, but then, okay, once they had it, they paid for it out of pocket without any reimbursement. And so, due to sort of services and volume being down, they were almost financially in a bigger hole. And once they had it, how do they get it to the clients safely? And how do they get it to the workers? And just this whole snowball, sick pay, right? So in New York City, workers were designated as sick pay, which is fantastic as home healthcare workers. But if you ask agencies, they said, well, we paid for that sick pay. So again, coming out of, there wasn't some, federal stimulus for that. And so on the agency side, I think also the technology, and I know I see Dr. Estrin on the line, but all of a sudden, the switch from how do we get in touch with all these workers to constantly update them on communication. You had agencies that did not have technology infrastructure. So they typically would just call workers in the field who may or may not have a smartphone. And now you had to sort of rapidly, just like we had to pump out video visits, you had to rapidly change gears and try and get tech infrastructure in place to do these screener questions, to get workers' email addresses, to send them information. So on the agency side, it was really challenging. On the union side, the union collectively, was able to advocate for, some hundreds of thousands of dollars of PPE donation, and also some lobbying for a few of the federal bills that were recently passed in May. But they too have had to switch gears. So, typically workers get annual training. How do you do that when you can't bring workers in person? And so this had to be done online. And how do you get folks who don't have computers online training and on COVID? And I think the union has been fantastic in providing courses on mental health, coping. As you can imagine, just like us in the hospital, when patients were dying, workers were witnessing clients dying in the home. And so how do you help them cope with that? And so I think I can advance the slide, but some of the current, here are just to answer some questions. There are obviously challenges, and agencies and unions are now telling us about them. But to date, I think there have been some progress forward. And you can just see some pictures of websites. But I think there's all these other areas that still need a lot of work. So I hope that answers the question. But yeah, agencies were in a really tough spot. We're documenting that now, and union was as well.
That does answer a lot of it. The second question was sort of related to something I saw in one of the slides where a home worker, home health aide said that they called the doctor to talk about a cough, and it made me think that a possible intervention might be to think about, building the video visits into these patients. If they're sick enough to have a home health aide and are high risk, should we keep them in a registry and build contact in with the home health aide during a pandemic, and give them a way to reach out to us with remote patient monitoring, with vitals that go into Epic, so we could spot their O2 sat starting to fall in advance or something like that. So it would be an intervention to build out with, as you mentioned, technology and support and all that, but it might be something to.
I think that's music to my ears. I think it also just speaks to, as of right now, like agencies are trying to do some of these virtual visits because now CMS is allowing payment for that. But of course, the data collected on the agency side is not integrated to us as the doctor. And ironically, before COVID, the aides weren't always involved in calling the doctor, but due to COVID, we found that a lot of them were. And so, yeah, you're spot on.
Dr. Sterling.
Yes.
Can I raise a question? This is Ollie Fine, and
Fine. Yes.
wonderful, wonderful work on your part. What occurred to me that's interesting is that during the time of the study that you were doing, there was a growing protest movement on the streets here in the city. And the whole issue of Black Lives Matter being raised as a higher issue. And I was curious if any of your home care workers mentioned anything about protests. Had any of them in any way thought of participating in them? And, you know, what was the impact of those protests on the work that they were doing?
As always, a fantastic question. I think we missed the protests in this study because we wrapped up at the last interview was April 25th or so. I can tell you that in this podcast, which I'm showing online, the editor and the guest speaker made the direct connection that this is sort of the perfect storm. You have a vulnerable workforce, majority, minority, and this is really, it speaks to the issues of inequity that we're facing with sort of exemplified in the Black Lives Matter movement. And so they actually in the podcast made that exact point. I think in the future, we can certainly ask them about the protest and sort of the desire to have voices heard. We just didn't, I don't have that data right now, but the parallel is very important.
I just thought that there may have been some side questions or side answers that came in around this, and I was curious. Thank you. That's great.
It certainly came up in the town hall that we had this week, so you're spot on.
There's some more questions, comments, accolades. This is a very exciting piece of work, and it's obviously been very nicely presented, and she got a very timely publication from this. And it's the kind of work that one hopes will bend the arc of the universe towards a little more justice. I think we should perhaps end on that note. Anything else you'd like to say, Maddie?
No, I think, thank you so much. That's, you know, as a clinician researcher, I think trying to do meaningful work that either affects clinical care or policy is sort of at my heart. And so I just feel fortunate. I had a really wonderful team and also the community partner without which this couldn't have happened. So thank you for letting me speak today.
Thank you, everybody, and have a good weekend.
Thank you. Yes.